Um, Organizing this conference, any conference is difficult and time consuming and takes a lot of effort and dedication from all of us. So I wanted to personally thank the chair of Department of Plastic Surgery here at the AUMC who graciously hosted us here, my colleague, Dr. and Fleur, who have been quite helpful in helping us with organizing this. Without further ado, just wanted, can you hear me better now? This microphones are just a bit, let me see if I can use one of this. Yeah, let me use that. Is this better? All right, thank you. So here we are in Amsterdam for our 6th annual meeting. This is a true international meeting. Hopefully more and more of our speakers and audience will attend here. We have representation from 20 different countries. And truly, although the numbers in this room and in Zoom are small, but everybody who is here is quite passionate about this condition. That's why we are gathering here. And every year this number increases. And we are very happy to have all of you with us. We have individuals joining us from Australia, Belgium, Brazil, Canada, China, France, Germany, India, Jamaica, Japan, Morocco, home country, Netherlands, New Zealand, Nigeria, Poland, South Africa, South Korea, Switzerland, United Kingdom, and USA. Very happy and proud to have you with us. I think the purpose of this meeting is not just to be a one meeting. It's an effort that we wanted to continue for decades to come. So some of us who originated this are aging. We need to have more blood, young blood, to carry this forward. This is an effort with the vision of next 50, 100 years. Some of us won't be here, but we hope that this meeting, this process would continue. Again, my thanks to all the faculty who have joined us, both in person. I have to admit this, my faculty, all of us, we join here and pay for our own expenses. We are not an organization that is sponsored or supported by any outside entity. We have some minor support here from 2 local companies that Frank later on will introduce. But for the most part, all of our faculty pay their expenses and travel, take the trouble of coming here without any expectation whatsoever. Nobody gets reimbursed for presenting here, and everybody actually spends money out of their own pocket to come here. So we are truly passionate about this, and we love that, and we hope for this to continue to be that way. Many thanks to our attendees. And hopefully the attendees will become speakers of the future. We want you to not only be an attendee, we want you to share your experiences. We learn from each other. So please keep that in mind. If you're not presenting this year, I want you to present next year and the future. And my co-organizers, I already introduced. Frank is based here. He spent quite a bit of time, lost sleep over issues related to this conference. I really thank you, Frank. And Frank has been with us from the beginning. Our first meeting was in 2016, and Frank has been with us. And Flora and Tracy have been quite helpful in organizing and helping us. And of course, the Department of Plastic Surgery. This is our 10th year inaugural. Our very first meeting took place in New York City. And Dr. Prema, thank you for coming all the way from India. Dr. Prema has been one of our main supporters and speakers all the way from the beginning, from 2016. And some of you have been with us since 2016. Lamont was there present at Rockefeller 2016. Frank was present Dorothy, you were present as well. And then gradually we picked up more speed and we had others joining us. That was the auditorium we were at Rockefeller at the time. There's a few of us at the end of the meeting with Dr. Yobin Wang and Dr. Cooney, who's joining us, Damon Cooney, here all the way to the left of the screen from Hopkins. He's attending this meeting remotely today, and he was present there in person at that time. We had a one-day meeting in Marrakesh in 2017. This is just giving you a background as to where we are coming from and where hopefully we will be heading to. And that was our, one day by invitation of the Moroccan team. And we had a large group of people attending. We had our second formal meeting in Rome in 2018 in collaboration with ISDS. Some of you were present there, you're present here today, and I'm really proud of that. And we hope that these numbers would gradually increase. And we're all aging with this meeting as time passes. Frank and Henry outside the conference hall, we were at the theological university then. At that meeting, our colleagues from Beijing invited us to take our next meeting to Beijing. So in 2019, we were hosted by our team in Beijing, and we had a wonderful meeting there. And a lot of us attended. You can see yourselves here, Jonathan in front. And many of you were present there in that meeting. Junio Ito was present there. I'll say a few words about him. Then COVID happened in 2020. We were planning on holding the meeting in Philadelphia in 2020, but because of COVID, we couldn't. So the meeting took place in 2022 in Montpellier. And again, some of us were here, were present then. We had one of our colleagues whom we lost, Mark Fear. We don't have a pointer here. Do you have a pointer? Can you get a pointer for us? Okay. No, this doesn't have a laser pointer. No, you can't see that's okay. I'll get to that. Anyhow, then last year, we graciously were hosted by our colleagues in Shanghai. It was almost this time last year that several of us were in Shanghai. And that was a wonderful meeting with the help of Professor Wei Liu and Professor Wu, who really went out of their way to organize the meeting for us. You see them in this picture facing us, and Professor Yobin Wang. Here, I'm in Montpellier with Junio Ito. This was 2022, September or so. Uni unfortunately passed away at the end of that year. It was a great loss. He was the chair of Department of Dermatology at Thomas Jefferson and was one of our strongest supporters of KRF. With him, we actually made a lot of progress, and he initiated the process of gradually making Thomas Jefferson the home for Keloid Research Foundation. Unfortunately, we lost them, and the future leadership is not interested in keloids. So we lost the main supporter. Uni is very well known was very well known in the research community with several hundred publications. Sadly, we lost another colleague, Mark Fear, last year to an accident as he was jogging. Mark has been with us in every meeting we have had, a wonderful, lively person from Perth, Australia, who has contributed significantly to the science of keloid and wound healing. We miss him dearly. This is him presenting in Shanghai. Okay, I'm glad you can see the pointer. Great, the Zoom attendees. So just a few words about Keloid Research Foundation. Established this several years ago, and purpose of it is very simple. This is a totally non-for-profit entity. We have poured money into this. Nobody has taken a penny out of this institution. Purpose of it is to foster research in keloid disorder, to be an educational resource, and to echo the voices of patients, to serve the patients, and encourage participation of patients and an audience. Just a few words about the meeting today. Meeting is made of two separate topics, clinical topics and basic science sessions. And the ultimate goal is to improve clinical outcome for keloid patients. No matter how and where we work, either in lab or in a clinic, our goal is to improve the clinical outcome for our patients. And what is very important to hopefully achieve is to, at some point sooner than later, to have data-driven treatment guidelines as opposed to expert-driven guidelines. Unfortunately, a lot of keloid patients are treated by experts, and expert-driven care is delivered, and this needs to change to become data-driven. We certainly need to enhance collaboration among ourselves and have an open mind to learn from each other. Several years ago when we started, and still to this date, some of our colleagues believe that surgery and radiation is the answer for all patients. If that was the case, we would not be gathering here today. So we are all here to find better methods of treatment for these patients and expand the armamentarium of treating patients. So a few points about timekeeping. During the breaks, you have the program. This was emailed to you. This year, we decided to do everything electronically by email. And also the program is available on the website of Keloid Symposium. So timekeeping is important, but again, we allow time for conversations and discussions. And I ask all of our presenters, just avoid starting the presentation with what keloids are. Everybody knows what keloids are. We don't need to repeat it 30 times during this meeting, and just start with the core presentation. Thank you very much. I thank you for listening to me. So with that, I have actually put myself as the first presenter of this meeting. That's hopefully will change soon, but let's just make sure that this is presented. And let me make sure that the audience on Zoom can see everything. We are broadcasting this in Zoom, and just wanted to make sure that everything goes smoothly. Can audience in Zoom type a note that you see the new presentation? Can somebody type yes or no? Yeah, I know here we see it, but I just want to make sure that the Zoom audience can see it. All right. So every year that we started this meeting, my presentation was about the clinical presentation of keloid disorder and what it is that we are looking at. We have done that many times, and most of you are familiar with that. So this time, changed the topic to talk about challenges that we all face with this disorder, and try to go through that and hopefully together try to find solutions when I started this presentation, it crossed my mind that I'm complaining. I'm complaining about different things related to this condition. Um, I hope that would not come across as complaint, but as bringing up an issue and getting us to troubleshoot it and brainstorm it and try to find solutions for it. So I have no conflict of interest with any of this. So we all come across patients with all kinds of keloids. And you can imagine, even the simplest one with a small keloid on her ear to these other patients with more advanced keloids, each one basically poses a challenge, a treatment challenge. And as you see these, each one of us, the way we treat these patients, think of a way of how we would be managing these patients. But this is a challenge. So this is a very challenging patient to deal with, all of these patients. So discussing challenges is a challenging topic itself. I mean, standing here before you and talking about what challenges we have, what challenges we have dealt with is actually not a difficult, not an easy task. It's a fairly difficult task because you cannot be complete. And we all face a lot more questions than answers that we have for this condition. And as you brainstorm yourself as we go through this presentation, you will come across and you'll come up with more challenges that I perhaps can't even cover here. And there is a significant gap in our understanding of disease's biology, how we can prevent it, what best treatments are there. So together, hopefully with you, we'll identify some of these challenges, some of them that I'm actually going to overlook and won't discuss here. Clinical challenges, as we discussed, managing these patients, research challenges. As a clinician, I can tell you what challenges I deal with, but you as researchers in the laboratory deal with a lot of challenges. Educational challenges, to educate our colleagues, healthcare workers who deal with these patients, as well as patients themselves, so they better understand what they have and what is the disease that they are dealing with. Patient care challenges, issues related to delivering care to these patients, issues related to regulatory and industry barriers, including using new drugs, using unapproved drugs, or trying to get industry and pharmaceutical industry to work with us. So we hopefully we'll identify some of these, and at the end of this talk and at the end of the session, we want to brainstorm together what we want to do. And today we have a session at noontime that we can brainstorm a little bit more to identify important challenges and figure out the paths forward and how we can accelerate the progress and at the end improve patient outcome. I already mentioned that unfortunately treatment of these patients is expert dependent as opposed to and consensus as opposed to being data driven. And much of that because of lack of effective treatment, lack of interest by pharma within this disease. This is one disease entity that not a single company has ever put a drug before the FDA for approval in this entity. Think about psoriasis, think about acne, think about peptic ulcer disease, think about asthma. There are tens of drugs for each one of these conditions, not a single one for this condition. And we know the patients, many of the patients I have already shown you, these patients need systemic treatment. We don't have any for them. And this room is not filled with people who are passionate about this condition. There are a few of us who are really passionate about this. So there is lack of interest within academia, basically, and lack of robust clinical and biological data. We just have limited data, limited information. And that lack of data is the biggest single challenge that this condition deals with. Lack of large-scale clinical trials. We are limited to studies that report on 10 patients, 20 patients, 40 patients, etc. We were talking with Dorothy last night, reporting on one patient. It's just difficult. And this results in expert opinions and how experts treat the patients. We know this patient didn't wake up one day with this. And she has been through a ton of our treatments. So you can see scars of surgery, marks of radiation, and disease progression everywhere. And you just can't believe what she lives through. And this is a challenge for all of us and for this particular patient as well. And she lives with that every single day. This is the teenager, is 16 at this time that he came to me. What's going on there? Why don't we have a treatment for this? How can we get there? We talked about, hasn't been a single FDA drug, there has never been a drug put before the FDA. Most treatments that we have, that we use, deals with 1 keloid or 2 keloids locally somewhere. We do whatever we do, we just manage 1 or 2 keloids or larger keloids, but some of these patients need systemic treatment. Lamont talked last year about recurrence and recurrence rates, and recurrence remains a major issue after surgery, despite everything else that we do. I mean, that tells us that we lack understanding of why does the recurrence happen, and what goes on biologically. Treatment options are quite limited, and that is limited because of everything that I just discussed with you. We don't have any standard treatment guidelines. We've created some, but again, hardly being used. And still, I'm in WhatsApp chat groups with scarring groups, and every once in a while I see somebody posting a picture and they ask, what would you do? And some expert decides, this is how I would treat this patient. This is where we are, unfortunately. I'm an oncologist. In oncology, we have NCCN guidelines, National Comprehensive Cancer Network guidelines as to how to treat acute leukemics, how to treat patients with lung cancer stage by stage, based on molecular markers. We have none of that for patients with keloid. And biomarkers, Lamont will talk about some biomarkers that he's working on. But again, we need to have a lot more biomarkers of this condition to predict how the patients are going to do, because all patients are different. We cannot look at 20 patients and say they're all the same. So there will be one biomarker that will reflect the disease entity. Clinical data sets are very limited and insufficient simply. As a result, we have very limited understanding of the disease biology. We don't know much about this molecular changes, what pathways are abnormal, what goes wrong. In oncology, we have a lot of understanding of different cancers and what goes wrong within these tumor tissue that leads to development of a cancer. But here, we don't know anything. This is a genetic condition. Later on, I'll share some data with you. If you ask, and you perhaps do, if you ask your patients, how many of them have somebody else in their family who has keloids? More than 50% tell you they know of somebody else in the family who has keloids. And that tells you this is a genetic condition. We don't know it's genetics. We don't know what gene drives it. There must be some mutation. There must be something there. Research that has been limited. There are all different factors that we know of. During COVID, a lot of patients had, rapid progression of their disease. You don't know why. It wasn't researched. There are environmental factors. Much of it is completely ununderstood, misunderstood, not even understood. We don't have a method we came up with the staging program for it in 2016, but we don't, this is not well recognized, and we don't have a scale of assessing the severity of the disease or staging that everybody would use. Trials we talked about, we don't have any. And again, all of this leads to reliance on expert opinion. Access to care is another problem. You go to different countries. I mean, if you're in a hot center, referral center, you have access to experts, you have access to plastic surgeons, dermatologists, etc. But many people across the world have no access to care. Simply the disease progresses. Think about Africa, where the keloid is the most common, and the limited access and resources that they have Financial barriers, unfortunately, at least in the United States, most insurance companies consider it a cosmetic problem. They don't cover the cost of treatment. That's our fault because all of our literature talks about keloid scarring. We did it ourselves. When we call this condition, these tumors, keloid scars, insurance companies pick up after that. So, oh, scars. We don't treat scars. Scars, cosmetic. We don't pay for it. And you have seen some of the patients I've shown you. We know that there's geographical disparities. The disease is very common in Africa among dark-skinned individuals, and in Asia, less common in Northern Europe and among Caucasians. Why is that? Where is the link? We don't know. These are important things to basically understand. Treatment. Patients who have lots of resources, money, they can get more treatment. Patients who have no money and have no resources, the disease progresses. As a result, the diagnosis is delayed, treatment is delayed, and we end up with progressive disease. This is an example of insurance company basically telling this patient whom I send a letter to describe what we wanted to do for a very large ear keloid that, hey, this is a cosmetic problem. We are not covering the cost of treatment. This is black and white, Horizon Blue Cross Blue Shield. Psychological challenges, the patients that I showed you, they live with this disease and they basically are quite stressed by it, by not only by chronic pain, some of these keloids are quite painful, especially if they become infected. Itching is another problem. Disfigurement, the appearance of the tumors in areas that people can see. These are all challenges that the patients basically face. And a lot of them have mental health issues, impacts them not only physically, not only pain and itching and discomfort, but also depression, anxiety, withdrawal. All of these are real challenges for the patients. And some patients, especially, this is a disease of youngsters. They get stigmatized at colleges, at universities, at schools. Overall, it basically reduces quality of life of the patients. How can we impact that? These are real challenges. There are many public health issues. This is not recognized as a chronic disease. CDC doesn't follow this. We don't have epidemiological. What's the incidence of the disease per year per country? We don't know. How many patients develop it? We don't know. How many African Americans in the US have the disease? We don't know. I mean, just so many unknowns that need to be resolved. And much of it comes from limited funding that has become even worse recently in the United States. Limited or no pharmaceutical engagement. I mean, right now, I'll show you some of the things that pharma is doing, but it's just very limited. You don't have Novartis's, you don't have Merck's, you don't have Pfizer's to really put resources into this and get to the basic science of it and fully understand what goes on so that we can find pathways that are abnormal that we can drug. We don't have any of that. And patient advocacy, I mean, very limited. I mean, their patients have small online groups, but that perhaps is not adequate. So we can all think about what the future should be like with needing international registries to register these patients to fully understand what goes on with them. We need to have decent clinical and biological data sets. We need to have multi-center collaborative research. We need to standardize outcome measures. To this date, if you look at 5 different clinical trials that may enroll patients, each one of them uses some endpoint to measure the response to treatment. We don't have that unified. And certainly we lack some of the points I made already about data-driven guidelines, et cetera. So we really need to, in the future, work on getting more involvement by academia, by industry, by government, and move away from expert opinions. So where do we start? I'm going to ask you, I mean, anyone, where do we start? How do we tackle this problem? We can talk about it now. We can talk about it during the break or after this presentation, but it's very hard. That's where we start. So many issues that we need to tackle. We basically need to have a lot more of us who are in this room to basically form an army to address different aspects of this condition. And this challenge goes from kids. This child reported her having developed a keloid at the age of 9 months. She's at the age of 6 at this time, to this gentleman who is 81. This is a disease that basically doesn't know age limits. It's something that we basically need to address. Just want to spend a few minutes on challenges the patients face. It's a patient who wrote to me that I'm a college student. She's 20, and she has been struggling with keloids for about 8 years on both her earlobes and has had 4 surgeries, which all have been counterproductive and caused her keloids to grow back about 6 months after surgery. She even had radiation therapy. That didn't work, and she's researching to find out what could be done for her. This is a recent patient who came to my practice in April, actually. This is very, very recent, so I'm not going to share any treatment outcome with her. But then this patient, I asked her, so why did you have 4 surgery? Who did your surgery? This is a patient who's in New York City. I'm going to share some of her challenges that she dealt with. And she told me, I worked with a doctor, and if you research the doctor, now later on, I can tell you more about this doctor. This is the doctor that this patient had gone to at this entity in New York City, Lexington Plastic Surgeons. These are all public information, by the way. And I don't like to criticize physicians. Just don't take it as a criticism of a physician. Just look at it as issues that patients deal with and how they can be deal with that. This is not that patient, another patient that they had a free consultation. It was a free consultation, come for a consultation. And then the cost of treatment is $10,000. Once they do that, they ask them for $8,000 more to treat their keloid. And this is real. And this patient goes and files a complaint with the Better Business Bureau. And this is a doctor who considers this is all public information. The patient went to this physician, is a board-certified facial plastic and reconstructive surgeon. And then when you look at them, they're the Joneses. We are the Joneses. And we are casting patients for session 2. If you are the Joneses, if you have a dynamic personality, thinking about having plastic surgery and would like to be considered, apply here. Let me see if we can play this video. Can you hear this? That's okay. So it's amazing. I mean, the surgeon operated on him. He looks great. He looks a lot better. But listen to him. Research 95% success rate in thousands of patients we have treated. Did you hear that? 95% response rate in thousands of patients we have treated. This is a publication that from the same doctor, Dr. Jones, and this is a summary of what he has done. If you take a look, this is about 44 patients. It's retroactive study. And look at the follow-up here on the conclusions. There's 95.5% non-recurrence rate at 1 to 3 months follow-up. Okay? I can tell you the non-recurrence rate 1 day post-op is 100%. Right? This is the data. He goes public with it. 95% success rate. So there are a lot of concerns here. I mean, this is all public information. That was a TV, that's on YouTube, this is his publication, etc. So we're using, I mean, of course, that patient with bad keloids, he helped him. Great. Very appreciative of that effort. But shall we use that patient as a commercial opportunity to go to TV with and talk about the research in thousands and falsify that? That's total falsification. Thousands of patients, 95% non-recurrence rate at 1 to 3 months. I mean, this is just aggressive marketing, promises high success rate when it doesn't exist, claims that this is research-based, which is not, claims large patient volumes, no transparency. And again, if you go back to his co-authors are his nurse practitioners in his practice. These are the co-authors. No disrespect to any nurse practitioner, but that is not right. So the same doctor gets a lot more complaints from different people. Somebody demanded to end the corrupt medical practices of Lexington practice surgery. This is another complaint that somebody had, again, free consultation. They wanted 6,500, then later on they wanted another 5,000. Goes on and on and on. I'm going to skip that. And then my patient said, that young girl, that the doctor is no longer practicing, it's all public, because he filed for bankruptcy. Because the reality TV persona, he got sued and he filed for Chapter 11 bankruptcy. And not only that, he was charged with fraud, embezzlement, tort cases, and sexual harassment cases. That somebody, booty surgeon, drunkenly hit an assistant. This is same doctor, $35 million lawsuit that led him into bankruptcy. We can talk about, we all need to market our practices. I believe in that. And we all need to generate income for ourselves. But there has to be a correct way of doing that. We should not be doing what this gentleman did. And hopefully you see some of the issues with this case that I presented to you. And then he publishes literature. I showed you one. This is two other literature that he has. These are two other things he has published. And the problem is this literature gets quoted. It gets cited. So people use that literature that's produced by this doctor. Who would trust his data? I mean, I just told you about who he is and what is that public information. I would never trust that personality's data. There's something wrong. But he publishes, gets published, and people cite it, right? Somebody goes, oh, the cure rate is 95%. And then, this just gets propagated. This is another, this is one of his publications that this has 2-year follow-up, perhaps. And again, I would never trust his data. This is the data that needs to be audited. Really, somebody needs to go, if somebody like him produces data, needs to get audited, but this gets cited by others. And his data get published. This is another challenge that we have. That data gets published basically and says there is no financial gain there. And I'll get to that in a second. Issues with medical literature. I'm going a little bit over time, but I'm going to stop shortly. So this is the dupilumab. We know a lot of these patients need systemic treatment. So we published a few years ago that this drug does not work for patients. Some of my colleagues decided, and we published it, to work on this drug. And there were 2 clinical trials by Regeneron from the company and renowned physicians at Mount Sinai that started in 2021 and enrolled somewhere about 50 patients, but there are no results published on that. A same study was done at Brigham and Women, and then they published some results that the quality control says, we cannot assess this result. This looking at effect on Vancouver Scholar Scale and poor quality poor quality data, information within measure that creates an issue when you don't publish the data. And we all know there's a fragmentation in the keloid literature. I mean, if you publish, every literature goes to all kinds of journals. We tried to put a journal together, Keloid Research Journal, about 10 years ago, and this just unfortunately does not get enough support. This has been going on for several years, and we hardly get anyone to submit literature to it because we are not PubMed listed, or we are not indexed by PubMed, which creates a whole issue as to why PubMed is not indexing us. But PubMed indexes this literature that I showed you that gets published in Advances in Wound Care. This is where some of our literature goes. And I want you to know that these journals that publish for you, if you look at the website, they will talk about banner advertising. They talk about channel advertising. It's all about money. They make about $100 to $140 million a year. And they started with a 24-year-old. And these are the other journals that have been going on and they make billions of dollars. So this index that you follow as impact factor, it just pays them billions of dollars a year. That's where your publications go to. Anyhow, I have a lot more to say, but I'm going to stop here. I'm going to invite my colleague, Frank, to come and continue. Oh, Dr. Prema. Sorry about that. Thank you very much. So let me close this presentation. Dr. Prema. Dr. Prema is a plastic surgeon joining us from Chennai. She has been a wonderful supporter of Keloid Research Foundation. And let's just make sure that the audience